right, I'll be speaking on PRRT as the first line gastro neuroendocrine neoplasms. Now, as we know, PRRT has been around for a very long time, and it has never found a very definite role in the sequencing. I mean, there have never been a very good controlled trials which will put it in a firmly in one particular place. What brought us onto the scene was, of course, the NETTER-1 trial, which conclusively showed that the progression-free survival of PRRT, when it is combined with the state-of-the-art current first line, which is the somatostatin analog, when it is given as compared to giving SSA alone, the progression-free survival of 28 months as compared to only 8 months with only the somatostatin receptor analog was given. And the response rate in the PRRT group was 13% versus only 4% in the LAR group. And there were far more deaths in the LAR group as compared to the PRRT group. So this basically put the PRRT, peptide receptor radionuclide therapy, firmly in the forefront in the management of neuroendocrine tumors. Now, the question is, there are so many modalities available for the therapy, including surgery, including radiological interventions, including chemotherapy, that there has always been a debate of when to use PRRT, where to use it, can it be used right in the beginning as the first line? And this has led to a lot of trials being planned, which are ongoing. I'll be discussing a few of them. But before we do that, one of the most important things which is necessary for PRRT to be used is the expression of the somatostatin receptors on the tumor. And we are doing the gallium DOTA knock or DOTA-TATE scans. And if we find the expression which is more than the liver or more than the spleen, what we call as the Krennings 3 or a Krennings 4 score, these are the patients who are ideally suited. And when we have this sort of an intense uptake, then the chance of response of PRRT are very, very high. And in this situation, you probably can use it as the first line therapy straight away without waiting for anything. One more thing which we have to do now, which has become a routine, is combine a gallium DOTA-TATE scan along with an FDG PET scan across all the diagnoses. So far, they have been saying that only if the KI index is more than 5 or 10, you do a glucose scan, FDG glucose scan. But we have been doing it in all tumors. And you can see here is a G1 tumor with extensive disease all over the body. On the FDG scan, there is no uptake at all. This is a classical G1 disease. As opposed to that is a G2 disease where you are seeing fair amount of uptake on the gallium DOTA-TATE scan, and you are seeing uptake on an FDG scan also in these lesions. And you are finding the G3 disease where there is intense uptake of FDG in all these multiple metastatic lesions. But of importance to note is that there is still significant uptake of gallium DOTA-TATE in this so-called G3 tumor. Mind you, when you take biopsy, you're taking it from only one side, and the FDG scan and the DOTA-TATE scan gives you the full image of the body, and it can map out the heterogeneity of the tumor. Some of the lesions may be G2 or G3, some of them may be G1. So it is now very necessary to, before classifying the tumor as G1, G2 or G3, to have imaging diagnosis based on a combination of the gallium DOTA-TATE scan as well as the FDG scan. Then we turn to the available radionuclides. We have now 3 major isotopes: lutetium DOTA-TATE, yttrium DOTA-TATE, and now actinium DOTA-TATE. Now, actinium DOTA-TATE is a recent entrant onto the scene. It is a alpha emitter, and alpha emitter is 100 times more powerful than a beta emitter, which is lutetium or yttrium. And alpha emitter also has a very short range, so it destroys locally. It does not penetrate. It does not cause much of damage to the bone marrow. So I think in future, alpha therapy is going to be a very important role to play, We do not use yttrium in India because it's not available routinely. And being a very powerful beta emitter, it penetrates and it can cause more amount of kidney damage and bone marrow suppression as compared to lutetium. So as far as PRRT is concerned, in India, lutetium is the mainstay, and actinium is coming into the picture when lutetium is somehow not giving the desired result. So basically, you have to have excellent expression of somatostatin receptor. And once that is established, then we are going to give lutetium in 4 cycles at 12-week interval. And the world literature has shown that 80% of the tumors show either some response or the disease remains stable. We come into the picture when the disease is progressive, when it has advanced in spite of the somatostatin receptor analogs. And with this progressive disease, we are able to arrest the disease or show some regression 80% of the time. And the mean progression-free survival is more than 40 months, which is fairly high. And it compares favorably with all the chemotherapy and other therapies which are available. And a very important aspect of PRRT is that it is very well tolerated with very minimal side effects, which are usually very transient, such as nausea, vomiting, abdominal discomfort, and a very subacute hematological toxicity grade 1 or 2, which is also again usually transient with some temporary hair loss, renal insufficiency. Recently, there have been some reports of myelodysplastic syndrome which occur in about 1 to 2%. There is no link between the number of therapies we have been given and the presence of myelodysplastic. We really don't know what makes a person susceptible to these myelodysplastic syndrome. And liver toxicity, especially if you are given embolization therapies with the radioactive material and then you give PRRT, then it causes a double whammy, and there the toxicity on the liver goes quite high. And we have usually quite often get such dramatic responses where you have such extensive disease and it has gone completely away, almost a complete remission after 4 cycles of PRRT. So it is now quite clear that PRRT is successful in reducing the tumor burden. It improves the quality of life. It prolongs the time to disease progression. And the current recommendation for PRRT sequencing restrict it to metastatic, inoperable, progressive midgut NETs, according to the NETTER-1 trial. However, this may change with the emerging data to suggest that PRRT is useful as a neoadjuvant therapy. That's the first line. When you diagnose it, there are multiple tumors. You want to reduce the tumor size to make the patient operable. It's getting an emerging role now as a neoadjuvant therapy for inoperable tumor to reduce the size and to make it operable. It is definitely better tolerated than other modalities after the somatostatin receptor analog therapy. It can be also used as a salvage therapy on relapse after prior successful PRRT. We usually give 4 cycles, then the patient stabilizes, we follow them up. If the patient progresses again, we can restart a second round of PRRT and with the fairly good results. So the question for this talk was, can we give PRRT alone as the first line? There has not been much data on this, but there was this quite an interesting study which was done in 2018, where they retrospectively examined the survival and response rate of patients treated with somatostatin analog as a combination therapy with PRRT, like was done in the NETTER trial, or as a maintenance therapy after PRRT, as compared to those who were given PRRT alone up front, right from the beginning, without starting the somatostatin receptor injections of LAR. They were given straight away PRRT, and they compared the two, but they found that somehow a significantly better progression-free survival, overall survival, and lower death event rate could be achieved with the combination of somatostatin analog and PRRT in patients with advanced gastroenteropancreatic neurokine tumors compared to with the cohort of patients treated with PRRT alone. So from this study, it seems that the combination of PRRT along with SSA, the sandostatin LAR, is better, and giving PRRT alone as the first line is according to this study, was inferior to giving them both together. So probably we need more data to make a final conclusion on this. So at this point, it seems, as was done in the NETTER-1 trial, this combination is better, and you probably should not give PRRT alone front, but you should combine it with, but the heterogeneity of the neuroendocrine tumors is such that probably you'll have to take a call in each patient individually. And if you have an extremely high uptake of tracer on the gallium DOTATOX scan, then probably you can try PRRT alone upfront, taking into the unique cost structure in India, where the somatostatin injections are not very cheap, and you have to keep giving them, and combining both the therapies together will certainly add significantly to the total expense to the patient. Now, there are several ongoing trials which are using PRRT in combination with other chemotherapeutic agents or other targeted therapy agents upfront. You diagnose it and you start using combination therapies, and we want to see whether these combinations end up giving us better result. Now, one important interesting trial is the COMPETE trial, which is a phase 3 prospective multi-center international randomized open label study that compares PRRT to everolimus on patients with inoperable progressive gastrointestinal pancreatic neuroendocrine tumors. And the main focus is to see the progression-free survival and overall survival. Everolimus alone versus PRRT in this group. There's the other ocular random trial which compares sunitinib with PRRT. Then there are control nets trials where you are using capecitabine and temozolomide along with PRRT compared to Captem alone. And there are several other trials where they're using pembrolizumab in combination with liver-directed therapies as opposed to pembrolizumab and PRRT. So the last word is not out. PRRT has come to stay. There are several features which will make your decision: the availability of PRRT, the cost of PRRT, whether patient can afford a simultaneous first line state of the standard of care, which is the somatostatin receptor analog. But if cost is the issue and PRRT is available, there are centers in India where PRRT is given free of charge. At the Radiation Medicine Center in Mumbai, the patient is charged something like 5,000 or 10,000, sometimes even free. So in such a setting, it may probably be the first line. You don't have to spend money even on the somatostatin analog, especially when the uptake of the receptors is very, very high. So that is the conclusion. Whether you want to give it as right in the beginning depends on several factors, but the most important factor is the expression of the somatostatin receptors. And even in G2 and G3 tumors, even if the expression is of the receptor is very high, you are going to give PRRT along with the Captem and other therapies. I think that's my last slide. Thank you for your attention.
Thank you, Dr. Lele. Thank you so much.
Can I have one question, please?
Sure, sir. Sure.
So, Dr. Lele, it was wonderful talk, and I have a question. I'm a surgeon, and we have a couple of occasions, as you mentioned in your talk, about neoadjuvant PRRT. And I would believe that this is most practiced in pancreatic neuroendocrine tumors. And my question is that how many cycles you would recommend as a neoadjuvant treatment, and what would be the good time? Because in one of the surgeries that we did, we encountered a lot of desmoplasia after PRRT.
Yeah, actually, there was an interesting paper from USA where they found that this fibrosis, which was feared to be a effect of giving PRRT, was not such a major issue. I don't know whether the Indian experience will be different, but the fibrosis was always feared that it will make your surgical bed difficult. But in their experience, it did not really matter. And in fact, it reduced the incidence of thrombosis also less. in the vessels near the pancreas. And the number of cycles to be given, we would still like to give the full 3 to 4 cycles. Maybe we will reduce the duration instead of giving it every 3 months, which will prolong the duration to more than a year before you can operate. We can reduce it to even a month. The range of giving PRRT is between 1 to 3 months for each cycle. So by reducing the time, you can give the cycles quickly and achieve a significant reduction. The studies so far have shown that you can have a reduction of up to 1.5 to 2 centimeters in the size of the tumor, which I think will be good for the surgeon, especially if there are multiple areas. Right.
Thank you.